Hi, I'm Rafael Linas. I'm one of the neurologists here at Johns Hopkins, and we're going to go over the neurologic exam. When I was a medical student, I really loved physical diagnosis. It was my favorite thing to do, and I did all sorts of different types of specialties, and it was neurology that captured my imagination because the exam was so great. There were so many aspects to it. You could pull out so many abnormalities, so many interesting things. What we're going to do is it's usually best to organize it in sections, and that's the best way to remember it. First is mental status, and then we're going to talk about cranial nerves. We'll talk about motor, talk about sensation, reflexes, and then coordination of gait, and we'll move through it in this way. Now, as I demonstrate the exam, I'll probably end up doing just one side at a time. And that's to shorten the film, but in general, when you do the exam, both sides need to be done. We have Ms. Williams here, and she's in a gown, and this is excellent for being able to get to all the joints, to be able to see all the muscles, to be able to reduce the sleeves or the skirt in order to be able to see the muscles. For the most part, if patients come in with loose clothing, so you can roll up the sleeves or pull up the shorts to look at the muscles, that's perfectly fine. Most people come to a physician's office dressed formally, and in those circumstances, usually placing the patient in a gown and at the edge of the table works well. So first of all, we have Ms. Williams. Hi, Ms. Williams.
Hi.
And what you can see is when you speak to her, she looks right at you. She's awake and she's alert. She's not falling asleep. She's not comatose. She tracks you. She reacts normally. So those are always good. Can you tell me your name?
Charlene Williams.
Great. And can you tell me about what the date is today?
Yeah, it's May 12th, 2011.
Great. And what's the name of this place? Where are we?
Johns Hopkins Hospital.
Great. So the next portion of the mental status that we're going to do is attention and concentration. And for attention and concentration, the best way is to give people a task that they know well forwards and then have it do backwards. So serial sevens, that type of thing. I tend to like days of the week forward and backwards. Ms. Williams, can you say all the days of the week for me, starting with Sunday?
Okay, Sunday, Monday, Tuesday, Wednesday, Thursday, Friday, Saturday.
And so this is a memorized task. To do it backwards is a concentration task. You have to remember what day of the week is next and go backwards. Can you say them backwards, the days of the week, starting with Sunday?
Okay, starting with Sunday, Saturday, Friday, Thursday, Wednesday, Tuesday, Monday.
Fantastic. So she did that quickly and accurately with no problem. She is very attentive and has good concentration. Okay, the next section of the mental status exam we're going to do is aphasia testing. There are three portions to the aphasia testing. One is naming, another is comprehension, another one is repetition. So let's look at that, all those three issues in Ms. Williams. Can you tell me what this object here is?
It's a watch.
Watch. Very good. And what's the name of that thing right there?
Oh, it's the watch face.
And what's that part of the watch right there?
That's the clasp.
Right, so her naming is excellent. Can you repeat a sentence for me?
Sure.
Can you say, today is a sunny day in Baltimore?
Today is a sunny day in Baltimore.
And any sentence that you have them repeat is perfectly fine. I would recommend that it be one sentence that you ask lots of people so that you know what it sounds like when it's abnormal. And the last thing is, can you follow a couple of commands for me?
Okay, sure.
So it's very important when you have people follow commands that you don't do it yourself, which is something we see a lot of. So what we don't do is, can you point to the ceiling? And I see that every year. I have to put my hands behind my back. Then can you do me a favor? Can you point to the ceiling? Can you point to the way out of this room? Great. So we're going to talk a little bit about quality of speech and mood and affect. So Ms. Williams, how did you get here today?
I drove in my car.
Oh yeah? Did you have any problem parking?
As always, yes.
Welcome to Baltimore. Right?
Yes, welcome to the garage.
That's right, exactly. So just in that little piece of history, you can tell that she has a nice fluid language. She doesn't lisp. She doesn't lose syllables. She's also, even though she had difficulty finding parking, she has a sense of humor about it. All the sentences make sense and flow from one to the other. So a lot of mood and affect, as well as dysarthria, comes from the history. All right, so now we're going to go over the cranial nerves. The thing about the cranial nerves are there's lots of them, and so it's very important to go through each one. In general, the way I organize it in my own mind is you think about the cranial nerves that have their nuclei within the midbrain, right? So eye movements. You think about those that have their nuclei within the pons, so facial movement, facial sensation. And then those that have the nuclei within the medulla, so the lower cranial nerves, the hearing, swallowing, tongue deviation. So I tend to think about those along the anatomy of the brainstem nuclei. Okay, the first thing we're going to do is check the optic nerve and the oculomotor nerve. Okay, can you take your glasses off for me just for a second? Fantastic. And then what I'd like you to do is, can you look right at my nose here? And it's important for them to choose an object to look at, so when you come close to them, they don't have an accommodation reaction. And can you look right here? And the pupil is large and then constricts, and then is large again. And then you look on the other side, apply light, and come down, and watch it dilate. So for the next portion of the exam, we're going to check visual fields. The best way to look at visual field is have the patient look right at you in the face. You look right here, and keep both eyes open. And then you put your hands in between you and the patient. You don't want to have it too close to you or too close to them. You want to have it right in the middle. And for the most part, you want to have them look straight. And then I'm going to show you some fingers. Okay?
Okay.
How many fingers do you see there?
One.
And how many fingers do you see there?
One.
And how many fingers do you see there?
Two.
And how many fingers do you see
Two.
there? Now, some people test visual fields by wiggling their hand, which you can do. It tests a different portion of the brain. So you can see this here,
Yes.
right? And you see there?
Yes.
Does it look like clearly like 2?
Yes.
And what about there?
Yes.
Can you see it
Little,
clearly as 2?
Not clearly.
Not clearly. What about that? Can you see that movement
I can
there?
see that.
Can you see that clearly?
Yes.
Can you see that clearly?
Yes.
The distant peripheral vision is more sensitive for movement than for finger counting. So how many fingers there?
I don't see that. Oh, one.
And here?
One.
And here?
Two.
And here?
Two.
And which hand is moving?
The right.
And which hand is moving?
The left.
And which hand is moving now?
Both.
Fantastic. So for cranial nerve 3, 4, and 6, the best way to test it is to have the patient follow your finger or any other object. Can you look right at my finger here? And look right here for me. And then what I'd like you to do is look up and look down, and both those eyes move together very nicely. And look all the way over here. And as I have her move all the way over here, you can see that you can't see any white sclera in the medial aspect here, on the lateral aspect here, and that means it's normal. And then the other way, all the way towards me. For the 5th cranial nerve, I tend to just use my fingers and touch people's face. The face is very sensitive, it's very personal, so I always say, I'm just going to touch your face now, okay? And I touch here. Do you feel this here?
Yes.
And do you feel that there?
Yes.
Are those the same?
Yes.
And what about here and here?
Yes.
And here and here?
Yes.
For the 7th cranial nerve, we are looking at facial movements. So the first thing we do is we ask people to close their eyes tight. Close them tight as you can. Very good. And open your eyes. And can you raise your eyebrows up? And you can see that both eyebrows come up very nicely, and just relax. And can you show me your teeth? Big? There you go. Very good, and that's nice and symmetric. So for the 8th cranial nerve, a quick screening test is just to have them listen to your finger rubbing together. Do you hear this here?
Yes.
And do you hear it there?
Yes.
Either the same on both sides?
Yes.
So for testing the glossopharyngeal nerve, the best way to do this is to look at the back of the throat and watch the palate elevates as they say a vowel. So ah is usually what we use. You'll need a light, and a tongue depressor works fairly well. In general, what you want to do, instead of pushing the tongue down flat, you want to push it down just with the tip. It doesn't taste bad. So you have them open their mouth and you push down the tongue just a little bit, and at rest you look at the palate, and then you ask them to say ah, and you watch the palate elevate. All right. Can you open your mouth a little bit for me? Ah. Ah. So for cranial nerve 11, we're just going to look at the trapezius muscle. So I'm just going to move the gown a little bit to the side here, okay? And what you can see is you can see the trapezius muscles here. Can you lift up your shoulders like you're saying, I don't know? And you can see both muscles come up nicely and push down. Don't let me push you down. Strong, strong, strong. Great. Okay, now we're going to test cranial nerve 12. Can you stick your tongue straight out for me? And then what you can see is that stick it all the way out, and you can see the tongue is in the midline, and you can compare it with the front teeth, that the tongue is not moved to the left or the right. It's nice and midline. Always compare it with the front teeth and not the sides and the corners of the mouth. All right, so for the motor exam, we test several different subsections. One, we look at the muscles, and we look for atrophy. The second thing that we do is we're going to look at strength, and you test one side at a time. And then the last thing is we're going to check for tone. So for looking at tone, which is part of the motor exam, what we do is we'll look and we'll also feel, passively move the limbs to see if there is stiffness or a catch. When there's increased tone, it's usually indicative of a problem with the brain or spinal cord. Decreased tone tends to be problems having to do with the nerve or the cerebellum. Alright, so when looking at tone in the upper extremity, what we do is we ask the person to relax. Just hold on 1 second. Just relax like spaghetti. And you passively move the joint. And what you should find in normal tone is that you can passively move it without any stiffness, and the same at the wrist. It's nice and loose. Nice and loose at the wrist, nice and loose at the elbow. In the lower extremity, we'll straighten out that leg here, and then we pull back on the foot, and you have a quick movement up of the foot. When there's increased tone, it will be stiff, and there also may be repetitive clonus. So in testing the deltoids, what we have patients do is lift up their arms, just like sort of chicken wings like there, and then we test one arm at a time, and we put our hand right at the midpoint, and you push. Don't let me push you down. Strong, 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 strong. You should not be able to break this arm. If people are very, very strong, sometimes you have to move toward the elbow, but in general, you should not be able to break this muscle with your hand. All right, and in testing biceps, we have the patients hold up their arm, and then put your hand over the wrist, and you're gonna, don't let me pull you out, okay? And you often have to encourage the patient to exert themselves. So pull it in, strong, 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 excellent. For the triceps, or for the elbow extensions, we have the same position, and we tend to hold, and now push me away, nice and strong, 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 strong. And that muscle is nice and strong. For testing distal hand strength, we're gonna lift up the hand, thank you so much. And then we support the palm with your fingers and hold those fingers up, and we put our hand right close to the MCP joints and push down. Don't let me push down, don't let me break it. And you shouldn't be able to move the fingers at all. Can I see this side? Hold this up. I'm going to hold your hand here. Don't let me push down, don't let me push down. Strong, strong, strong. Great. So now we're going to go on to testing the lower extremities. So always remember that we want to be able to see whatever muscle we're testing. Can you just pull your gown off this area of the leg here? And then I'm just going to have to adjust it a little bit, okay?
Okay.
And just a little bit so you can see all the way up and down. Come on. Now can you lift this knee up? Very good. And don't let me push down. Nice and strong. Strong, strong, strong. And that's great. So now we're going to test the distal lower extremity, the tibialis anterior. And so the best way, I'm just going to take off your sock here, okay? You take off the sock. And can you cock your foot up for me? Very good. And the muscle we're looking at is here. Don't let me push down. Nice and strong. Strong, 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 strong. All right, great. So once we've looked at gross motor, one of the things that we can do is pronator drift, which is very good at looking at subtle weakness. So can you do me a favor? Can you hold your hands out like this, nice and flat, like you're holding a pizza? Now close your eyes and keep them nice and steady. And we observe her for about 10 seconds. Okay, very good. If it was abnormal, it would look something like this. Can you put your hands up like this and close your eyes and just hold this up? And what you can see is the hand gently pronates with subtle weakness. All right, so for the sensory exam, it also has several different sections. First is testing of light touch, and then is testing of pinprick. We'll test vibration, and we'll test proprioception. All right, and do you feel this here, a little light touch?
Yes.
And there, a little light touch?
Yes.
About the same?
Same.
Very good. And do you feel this here and this here?
Yes.
About the same?
Yes.
And then can I see your hands? And do you feel this here and this here?
Yes.
About the same?
Yes.
Fantastic. And then do you feel this here and this here? About the same?
Yes.
Great. And then what about here and here?
Yes.
And you feel them the same on both sides? Great. For pin and temperature sense, I tend to use the same Q-tip that you use for fine touch, and if you break it with your thumb distally, you can make a nice sharp edge. And then do the pinprick in the same locations. Now, what I tend to do is I tend to look people in the eye when I'm doing it, so they look at you in the face, so they're not necessarily looking at where I'm placing the sharp object. So I'm just going to test your pinprick sensation. It won't hurt, but let me know if it's uncomfortable.
Okay.
Okay? And look right here, and then do you feel this here?
Yes.
And it's a little sharp?
Yes, it is.
Is it painful?
No, it's not.
A little sharp.
Just sharp.
Very good. And then here?
Oh, yeah.
And here?
There, too.
About the same?
Yes.
Very good. Can I see your fingers? And then a little sharp here?
Mm-hmm.
And a little sharp here?
Sharp.
About the same?
Yes.
Fantastic. And then a little sharp here?
Yes.
All right. And a little sharp here?
Yes.
About the same?
Yes.
Fantastic. And then a little sharp here?
Yes.
And a little sharp there?
Yes.
About the same?
Yes.
Great. In the vibratory portion of the sensory exam, we use this tuning fork, And the way we strike the tuning fork is right against the palm of our hand. And then we take the base and put it against a bony prominence like a knuckle. Do you feel that vibrating?
I do.
Very good. And if they can feel it vibrating for 10 seconds, that's considered acceptable. So we bend down and we take the big toe and we bend it towards you so you can see the joint. Strike the tuning fork and put it right on the joint. Do you feel that vibrating there?
Yes, I do.
Very good. Tell me when it goes away.
All right.
1, 2, 3, 4, 5, 6, 7, 8, 9,
Gone.
10. All right, now we're going to test proprioception, first in the upper extremities and then the lower extremities. Can I see your hand for a second? So in looking at proprioception of the finger, we tend to hold it and put your fingers on the side of the finger, because if you move it up and down in this manner, they'll be able to feel the differential in pressure. So you hold the side of the finger, and now, ma'am, this is going to be up, and this is going to be down.
Okay.
All right, can you close your eyes for me?
Sure.
Did I move your finger up or down?
Down.
And up or down?
Up.
And up or down?
Up.
So you can see that there's very, very fine sense of proprioception. I'm just going to do it in your legs now, okay?
Okay.
And do you feel me here?
Yes.
Okay. Am I moving this up or down?
I can't tell what you're doing.
Right. And what about now?
Down.
Good. And what about here?
Straight.
And here?
Up.
Very good. And here, up or down?
Straight.
And up or down? And up or down?
Up.
So that shows us that the upper extremities are much more sensitive to proprioception than the distal lower extremities, but those are normal. So these are 3 different types of reflex hammers. They all have different names. Some people will swear by one reflex hammer type over another. The secret is that when you use one type of hammer, you become used to that, because the techniques for using all 3 are slightly different. In general, the most important concept is that when you strike a tendon, when you're striking a tendon to give you the reflex, that you should pull back with the same amount of energy. It's like hitting a xylophone. If you hit a xylophone and you don't pull back, you make tonk, you make a blunt noise. When you have a xylophone and you hit and pull back, you make a nice sort of clear note. And that's the concept behind reflexes, getting reflexes. A strike and a pullback. Okay, so getting the reflexes, the most important thing about getting reflexes is striking the tendon. So in the biceps, what we do is we put a thumb over, or any finger over, the biceps tendon. You should be able to feel it underneath your thumb. If you can't feel it, you can have people make a muscle. Can you go like this for me? And when she tightens up, you can feel the tendon come out at your thumb, and put it right over there and just relax. So my thumb's right on the tendon, and then you just hit the top of your thumb, and you can get that reflex. For the brachioradialis reflex, there's a very large reflex zone, so what I tend to do is put my finger over the radius bone and strike. And remember, you're striking down and with equal strength pulling back. Okay, so for the triceps reflex, what we have to do is we have to expose the arm a little bit, and then we're going to hold up the elbow. And now just relax. Now what happens, you want them to just relax the arm as much as possible. Just give it to me, just relax. And then strike right at the elbow. For the knee jerk, what you want to do is you want to strike the patella tendon. Now the patella tendon isn't exactly in the midline, it's slightly lateral. And what you want to do is you want to hit it a little bit harder, and with the same sort of movement forward and backwards, and you want to look right here for the muscle contraction. So it's going to hit here. So you can see the leg move, and you can see the muscle contract here. When we come down here, when we test the ankle jerks, we put the joint at 90 degrees and strike. And you can see the foot come down toward you. And we'll do it on this side. Oh, there's no reflex here. Can you do me a favor? Can you make tight fists for me? Tight fists. All right. So there's no reflex here on the right, and there's a nice one here on the left. Do you have back pain?
Yes.
Do you ever get numbness that comes down one leg?
I do.
So that's, when you lose a reflex, that's often a sign of a focal neuropathy, like a lumbosacral radiculopathy, and I would suggest that she has a mild S1 radiculopathy because of the dropped ankle jerk here. We're going to go on to see whether the toes go up or down. If they're Abnormal, it's referred to as a Babinski reflex, and what we're going to do is hold the heel in your hand, and you can take some sort of object with a very slight edge and come along the edge of the foot to the medial aspect, and you can see a little bit there. And what we're looking for is a normal flexor response. If the toe goes up and the toes all fan out, that's referred to as a Babinski sign. So, you okay here?
I'm fine.
All right, it's just gonna, doesn't feel great, but it shouldn't hurt.
Okay.
Okay? And a little tickle, 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 tickle. Good, and that one is down. So for coordination and gait, we tend to test finger to nose accuracy and heel to shin accuracy, rapid alternating movement accuracy, and there will be an amount of looking at tandem gait. In general, people who have problems with finger to nose will either have cerebellar or sensory motor problems. Specifically, if it's cerebellum, it's the hemispheres of the cerebellum. Midline problems of the cerebellum will present with problems with heel to shin and with tandem gait. Can you lift up one elbow for me, and can you touch your nose? And now can you touch my finger here? Back and forth, nose and finger, back and forth, nose and finger. Fantastic. Can you do it with the other side now for me? And touch your nose and my finger, and back and forth. And what we're looking for is that the movement is accurate and there's not much of a tremor. Very good. So the next portion of the coordination exam is looking at a rapid alternating movement. So can I have you take your hand here, and what I'd like you to do is tap on your knee 5 times. 1, 2, 3, 4, 5. And what you can see is it's nice and even and rhythmic. Can I see on the other side? 1, 2, 3, 4, 5. Fantastic. Okay, we're going to go on to the gait exam. So when you get people out of bed or out of a chair, you want to make sure that they're safe. So you doing okay? Are you feeling steady?
Thank you.
Can you do me a favor? We can do the Romberg's test first. Can you stand straight up? And can you put your feet together so they're touching? And now can you close your eyes? And you always just be careful. Make sure that you're ready to catch them if they're a little unsteady. Great. So now we're gonna watch her walk a little bit. Can you just walk normally?
Okay.
All right. And go ahead. All right. So for tandem gait, what we do is we have people put one foot in front of the other and walk heel to toe. It's very important that you are next to the patient while they do this, so if they become unsteady, you can catch them. And it's a very useful test for looking at coordination and motor problems. So we're going to have the patient stand on heels and toes now. Now remember, this is not a balance test, so you should hold them when the patients do this. First, you're going to have them stand on your tiptoes. Can you stand on your tiptoes? That's great. And now can you stand on your heels? So we're going to talk a little bit about heel to shin now. This is particularly important if you have a patient who you can't stand or you can't get out of bed, so that, at the very least this should be done to look for lower extremity ataxia that you would ordinarily pick up on gait examination. Can you do me a favor? Can you take this heel and rub it down, up and down that shin for me?
Okay.
Up and down, all the way up and down.
Tapes and light.
That's fine. You're fine. Up and down, and up and down. And can I see the other side? All the way up to the knee, all the way down to the ankle, all the way up to the knee, all the way down to the ankle. Nice, smooth movement, and she stays right on the shin, so that's great. So that's the neurologic exam as we're teaching. The important thing to remember is that the exam should be done in an order and presented in an order, and also to do all the aspects of it even if you think it's normal. So even if you think somebody has a normal mental status, you'll always surprise when you test people how there can be abnormality. So when you do the exam, it should be done in the same order, over and over again. Remember all the aspects of it, and difficulties will pop out at you the more and more you do it. The more repetition, the easier it comes.